I would welcome Dr. Prof.Yesudian. Paul does not need a big introduction, really. You know, we've all heard his talks over the years on various complex topics. He's a great teacher. He's an accomplished professional and a very supportive peer. So I look forward to get some pearls of wisdom from him on a topic of nodular prurigo today. Over to you.
Thanks a lot, Geetanjali, and thanks to Glenda for inviting me to speak here again. I think this is the first live BAD meeting since the pandemic started, so well done to the team. I hope you all have your fuel tanks full. I know it's an excellent meeting, but we still need to get back home. I'm going to divide my talk into 4 parts. Firstly, what is chronic prurigo? I myself, before Glenda gave me this topic, used to call it nodular prurigo. But there's a new definition, and that was given by the EADV, and it's called chronic prurigo. We need to know about the pathophysiology, what exactly happens in this specific condition. And then, of course, we'll go into the clinical features and the management. Chronic prurigo itself seems to have been there for quite a long time. So if you look back in old literature, if you go back to Cornelius Celsus between 50 BC and 50 AD, he described something called prurigo. So it's been there for more than 2,000 years. It's since then been used to describe any itchy condition. So Robert Willen, the father of dermatology in the UK, he used the word prurigo too, but to describe any itchy problem. The specific condition we know of, nodular prurigo or chronic prurigo as it's known now, was actually described by an American dermatologist called Hyde, and that was in 1909. And then, just like ABBA decided to release an album after 40 years, the EADV decided in 2018 that they need to be specific, and centuries of an old nomenclature has been discarded, and the last 3 years we call it chronic prurigo. So it's a new definition, and it came out of an EADV consensus paper, and it's actually an umbrella term for a variety of morphologies, which we will see. And it is a distinct entity because there are specific neuronal pathways which are involved, and specific sensitizations and specific itch-catch cycles, which is what perpetuates this problem. So there are 3 diagnostic criteria. The first is a historical criteria. It's whether the patient has experienced itch of 6 weeks duration. And as we'll see, it can be itch from any underlying problem. It can be a dermatological problem, a systemic problem, a neuropathic problem, psychosomatic, or it can be multifactorial and sometimes unknown. But they should have had itch for 6 years. That should be their first symptom. The second is both historical and examination. So you ask them in a clinical history, have you had evidence of scratching? Do you scratch your skin? And you can actually see it in your clinical features. Have they got lichenification? Have they got excoriations? And then finally, are there pruriginous lesions? Are these small, discrete hyperkeratotic papules visible? And these are the 3 main criteria which the EADV has proposed. There are other additional criteria, but these are the main diagnostic criteria. So what are the underlying etiological problems? It can be quite a few problems. It can be dermatological, it can be systemic, psychosomatic, neurologic, and multifactorial. And we'll look at each one of them in a bit more detail. Amongst the dermatological conditions, by far the commonest is atopic dermatitis. So those who have chronic prurigo are much more likely to have atopic dermatitis than controls. Quite a few other dermatological conditions have also been associated. Psoriasis, for example, you're 4 times more likely to have chronic prurigo if you have psoriasis. Other conditions like bullous pemphigoid and linear IgA disease have also been associated with pruriginous lesions. And in fact, sometimes multiple keratoacanthomas can also occur with chronic prurigo. This is a patient who had atopic dermatitis with chronic prurigo lesions. One important factor is you can't look at the chronic prurigo lesions and tell what the underlying problem is. They all look remarkably similar in morphology. There are more excoriations here because we know that in atopic dermatitis, itch is the primary problem. Systemically, quite a few systems can be involved. Endocrine and metabolic changes, malignancies, and then we look at the other systems briefly and sometimes infections as well. So with the endocrine conditions, diabetes is by far the commonest condition. Type 1 diabetes is 2.2 times more likely to give you nodular prurigo, and type 2 diabetes is 1.4 times more likely. And the reason is simply because with type 1 diabetes, it's been there for a lot longer, and all the underlying metabolic changes, the neuropathic changes, possibly predisposed to more itching. And that's the reason why it's more common in type 1 diabetes. You can get it with other metabolic changes too. Hypercholesterolemia, hypertension, these are also likely to give you a higher incidence of chronic prurigo. Amongst malignancies, it's most likely to be lymphoma. You're 2 to 5 times more likely to have chronic prurigo if you have lymphoma than if you have controlled skin. And one of the interesting things about lymphoma is sometimes it can be the presenting feature. You see the chronic prurigo first, and then you make the diagnosis of lymphoma. And it can be either Hodgkin's or non-Hodgkin's lymphoma. Looking at the other systems, there's a patient who had diabetes. And again, as I said, you can't make out from the prurigo lesions what the underlying problem is. But this patient had type 1 diabetes. So what are the other systems? Quite a lot of other systemic problems can give you chronic prurigo as well. By far the commonest is renal problems. We've all seen our renal patients having chronic itch, and some of them may be more sensitized and therefore get prurigo lesions. If you're having dialysis, you're 5 times more likely to have chronic prurigo. So the more severe the renal changes, the more likely you are to get chronic prurigo. Also, with renal changes, we don't know what exactly causes the prurigo lesions. They have so many metabolic changes, there are so many neuropathic changes with chronic renal failure. They all may play a part in bringing up the chronic prurigo lesions. Amongst the hematological conditions, I've already talked about lymphoma, but iron deficiency anemia can also cause it. In fact, in one series, they found that 27% of those who had chronic prurigo had some form of iron deficiency. The problem is we don't know what causes the iron deficiency. Do they have an underlying renal problem which makes them get iron deficiency? So we don't know if it's the iron deficiency alone which causes chronic prurigo. Amongst the pulmonary problems, those with COPD are more likely to have chronic prurigo. Cardiovascular and cerebrovascular conditions are also known to give you a higher chance of prurigo. And finally, autoimmune conditions, celiac disease and Hashimoto's thyroiditis has been associated with prurigo lesions. Amongst the infections, we know that HIV is associated with a variety of dermatoses. In HIV itself, if you have poorly controlled HIV, and if you have advanced immunosuppression, if your CD4 count is less than 200, you're much more likely to get chronic prurigo lesions. The other interesting thing about chronic prurigo with HIV is, if you treat the HIV, the prurigo lesions go away too. So there's a very nice connection between the prurigo and the HIV condition. Another infection which can cause you prurigo, which can give prurigo lesions, is hepatitis C. Quite a lot of psychosomatic and psychiatric and neuropathic changes can also give you prurigo. Depression is a lot common, 2.8 times commoner than control subjects who have prurigo, and anxiety is about twice as common as those who have control subjects. Interestingly, in fact, if you have anxiety and depression, it may be so bad that that itself may need some form of pharmaceutical intervention. Other conditions can also give you prurigo lesions, self-harm, eating disorders, attention deficit disorders. They can also be more likely to give you prurigo lesions. And then we come across the neuropathic changes. So many times we see patients with brachioradial pruritus with prurigo lesions, and that's a neuropathic change. It's the local nerves which gives you the problem. And it can be either the local nerves, as in posthepatic neuralgia, or it can be from the spinal cord, which gives you the brachioradial pruritus. So how can you combine this all? So this is the pathophysiological basis. We've already talked about all those conditions which give you chronic itch. So dermatological, systemic, neurological, psychiatric, multifactorial, and unknown factors. All those conditions give you itch of more than 6 weeks duration. And that's the induction stage. You then have a phase of prolonged scratching, which is again there in the criteria. And then in some patients who are sensitized. Not everybody who has these problems will get prurigo lesions. There's a certain proportion of them who get sensitized, and they go into the disease phase, which is the development of pruriginous lesions. Looking at all the literature, I don't think there's any specific reason why some of them get it, but my own thoughts are that it's probably got some genetic predisposition, because for some reason it does seem to be common in some ethnic groups. It's not that common in white skin, but it is common in darker skin. So there must be something genetic predisposing to this particular condition. Amongst the pathophysiology, there are two main things we need to know about. And that is, one, there is neural dysfunction, and two, there is immune dysfunction. And the reason you need to know about it is our treatment is going to be dependent on these two factors. We treat not only the immunological dysregulation, we have to look at the underlying neural dysregulation as well. So if you look at the neurological dysregulation, as early as 1934, Pottrier did biopsies and he found that the nerves were very thick. So obviously there's something going on at the level of the skin where the skin nerve endings are a lot thicker. More recently, we found that some of the factors, the chemokines generated by the nerves itself, are abnormal. So for example, neuropeptides like calcitonin gene-related peptides and substance P are much more liberated than in controlled skin. And one interesting thing is, histamine does not seem to be a major player in chronic prurigo. So the use of antihistaminics for nodular prurigo probably isn't the right choice. You may use it for its sedative properties, but histamine itself is probably only a very, very small factor. There are so many other chemokines involved outside histamine. You then have the immunological dysregulation. If you look at the histopathology, there are loads of inflammatory cells, including lymphocytes and eosinophils, but it's those chemokines liberated by the cells which seems to be important. With eosinophils, it's the eosinophilic cationic protein, and then the T cells seem to play a very important part. That's the reason why interleukin 31, that's the main cytokine for itching, seems to be very, very good target protein. Interleukin 4, which is what we use to stop with dupilumab, that seems to be very effective as well. So the newer biologics, where we target these specific chemokines, seem to be the future of treatment of chronic prurigo, because you're not being very broad and non-effectual by using histamine receptor blockers. You're being much more specific. Histopathologically, this is what we will see in our day-to-day practice. We can't really measure all those cytokines, but we can see these histological changes. And basically, it's just thickened skin. Is there hyperkeratosis? Is there acanthosis? There may be parakeratosis, excoriations. There's a dense dermal infiltrate of all these cells, including lymphocytes. And then sometimes you can get those thickened nerve fibers as well. You need to have some form of clinico-pathological correlation. So you look at the pruriginous lesions, you look at the histopathology, and it may fit. And the reason is, like in simplex chronicus, can also give you very similar histological features. So it's only by clinical and histological features that you can make this diagnosis of chronic prurigo. Going on to the clinical features, almost any age group can be affected. In fact, children can be affected as well. I do have 3 or 4 patients in my pediatric clinics, and they are very, very hard to treat. However, it is commoner in adults, and the reason is they are much more likely to have all those underlying factors that we've discussed about in the etiology. I told you that it is commoner in some races, and African Americans seem to be particularly susceptible to it. It's incredibly high. If you have atopy if any African American has atopy, they are much more likely to go into a chronic prurigo type of morphology. It's also commoner in Asians and Hispanics too, compared to Caucasians. So there seems to be some genetic predisposition to the formation of these specific lesions. So what are the clinical features? We've already discussed about pruritus. You need to have it for 6 weeks. But what's interesting is it's not just the chronic prurigo lesions that are itchy. Even the non-lesional skin, where it looks normal, that tends to be itchy as well. And that's a useful point to ask in our history. Are your prurigo lesions itchy, or is the normal skin itchy as well? And that's a useful clinical point which I've learned. They do spend quite a lot of time before they come to us, nearly 3 years before they present to the dermatology department. And we'll be discussing the various morphologies, and all the morphologies are common in women, except for the umbilicated lesions, which is the excoriated lesions, which is more common in men. What is the behavior that we need to elicit? All the patients will admit that they are scratching the skin. So they have the scratching behavior and they admit to it, and it's almost like it's an impulsive itch-scratch cycle. They are also aware that it causes injury. They know that they are causing injury. In fact, 40% of them will tell you that when they scratch, they are aggravating the condition. So they have very good insight into what's going on. But the same history is seen, whatever the morphology. And we'll discuss all the various clinical morphologies which can occur with chronic prurigo. Just a word about itch in the middle, if I may. And I think many physicians sort of disregard itch as being something which is not, it doesn't have dignity, they say. If you look at Dante Alighieri's book, The Divine Comedy, he says that there are various types of hell, and there are 9 circles of hell. The 8th circle, which is one of the worst, all the people there have eternal itch. That's how bad itch is. In fact, that's a picture of Dante Alighieri with Virgil. It's a painting by Gustave Doré. In fact, I remember my father teaching me. He said, pain has dignity, but itch carries repugnance. So when physicians see a person with pain, they are sympathetic, they are empathetic. But when they see a patient itching, they don't want to have anything to do with it. Of course, as dermatologists, we are different. So I guess the perception of itch itself is such a difficult entity, not only for us, but for our patients as well. So the morphologies, there are many clinical morphologies, and they may all coexist as well. Typically, it's a skin-colored or erythematous papule. It'll be thicker, it'll be hyperkeratotic, it can be excoriated, and they're usually fairly symmetrical, they're bilaterally symmetrical. And depending on what you see, you can call it chronic nodular prurigo if there are more nodules, chronic papular prurigo if they are smaller, umbilicated prurigo if they are excoriated, and plaque prurigo if they are really thick. One interesting factor is if you have papular or plaque prurigo, you're more likely to have an underlying skin problem. If you have nodular prurigo or umbilicated prurigo, it's more likely to be multifactorial. Another interesting thing is the duration. If you have a smaller lesion, for example, if you have papular prurigo or umbilicated prurigo, they have a shorter history. So using the morphologies, there are some things which we can gain clinically. Classic is chronic plaque nodular prurigo, and these nodules can be variable. There may just be a few scattered, or you can get hundreds of them all over the body. And the classical sign is that butterfly sign, which I'll show you in the middle of the back, where the patient can't reach. That's where you won't get any lesions at all. And typically, it's there in the extensor aspect of the limbs, it's there in the trunk, and you will see all the features of chronic itching. They'll have excoriations, they'll have lichenifications, so all the factors which cause the patient to be itchy. And this typically, that's an excellent review article, the Journal of American Academy of Dermatology, but remember, they don't use the word chronic prurigo, because in the US, they still stick to chronic nodular prurigo. It's only in Europe that we use chronic prurigo. And these typical hyperkeratotic papules, which are fairly symmetrically distributed all over the body. It can be significant enough that the patient will bleed. Many of our patients will tell us our bedclothes are spoiled because they've been scratching so much that they're bleeding. And that's something which you will see quite commonly. That's the butterfly sign. If you look at the upper central back where the patient can't reach it, that's the place where the skin will be completely clear. And that's a useful clinical sign to have. And the typical nodules, more hyperkeratotic. They're not juicy, they're not dermal, they're more epidermal in nature. And the interesting thing again is there are so many books, but they will show very few pictures of nodular prurigo in pigmented skin. And you can see how different it looks. You will not see the erythema, you will see only hyperpigmentation. And again, it's quite important to feel the skin, because if you look at post-inflammatory changes, it looks very similar. It's only when you feel the skin and it's raised that you know that it's active, particularly in those with darker skin. And here are the morphologies. So on the leftmost is a papule, that's papular prurigo. Then you have nodular prurigo, and then you have umbilicated or ulcerated prurigo, and then a much larger plaque prurigo. So those are the variations of chronic prurigo lesions. Just to confuse things, the Europeans have introduced another one, which is chronic linear prurigo, and this is just introduced 2 years ago. Very rare, but it can coexist with other morphologies. And this is the typical linear prurigo, where you can see it's really linear, and it can be mistaken for dermatitis artefacta. So how do you make the distinction between the two? So in the article, in the EADV, they propose that this is the way you distinguish between self-inflicted lesions and linear prurigo. It's the history which is important. In linear prurigo, they get chronic pruritus first, then prolonged scratching, and then you get the prurigo lesions. However, in self-inflicted lesions, it is different. They will manipulate the skin, they'll get self-inflicted lesions, and then they get the pruritus and the pain. So just eliciting those small changes in the history will help you differentiate between these two quite difficult conditions, because our treatment is going to be quite different depending on which one we diagnose. Going on to treatment, it is very difficult to treat, and almost all the treatments we have are off-label. There are case reports, none of them, there are just 2 or 3 randomized case control trials, but the goal of treatment is, 1, you want to break that itch-scratch cycle, and 2, you want to heal the nodules. And those are the 2 goals of treatment. We'll start off with topical things first, because that's what we have access to. High potent topical steroids, particularly under occlusion, would be the best option. So we have 2 tapes which we can use, fludroxycortide tape and betamethasone tape. And what these tapes do is they do 2 things. One is, because they occlude the lesion, they hydrate the surface of the skin. The steroid penetrates deeper into the skin and makes it more effective. The second thing is they form a physical barrier. So when you have something on the surface, you can't reach it, and therefore you can't scratch it. So those are the 2 ways by which something which occludes the skin makes it work better. You can also use intralesional triamcinolone, use at least 10 milligrams per ml. If it's limited, you can do it, but if there are extensive lesions everywhere, then that's not really going to be very practical. You can use other topical agents. Topical anesthetics have been tried, but it is difficult because they cause sensitization themselves, and they will only give you a transient relief from the itching. So that's actually not a very practical way of treating it. Topical calcineurin inhibitors can be used, and actually, rather than tacrolimus, pimecrolimus has more evidence. In fact, the only RCT is with pimecrolimus, not with tacrolimus. Topical capsaicin can be used. That's a substance speed depleter. The problem is that itself can cause irritation. So it probably is worthwhile using when you have a sort of neuropathic itch. So if you have brachioradial pruritus, or when there's a very localized form of itching, then you can use it. But for the more generalized chronic prurigo lesions from dermatological issues, that would be a bit difficult to use. Phototherapy is helpful too. So if you have a person who's a bit on the older side with lots of comorbidities, phototherapy is probably going to be better to use than just topical agents or the systemic agents we'll be talking about. So medically compromised patients are probably a good example of where we can use this. And there's no specific type of light treatment. You can use narrowband, broadband UVB, and PUVA, and there's no specific difference between its effectiveness. They're all equally effective. Going on to systemic agents, this is what most of us will probably use, because by the time they've come to us, they would have tried all the topical agents. And there are 3 different ways. You can have the immunomodulators by modulating the immune system, neuromodulators because the neuropathic changes can be changed, and then you have the newer agents, and I think that's probably going to be the future of how we're going to treat chronic prurigo. Amongst the immunomodulators, the commonest are methotrexate and cyclosporin, which we'll discuss. Azathioprine and cyclophosphamide have been reported, but I don't think it's that commonly used in clinical practice. Methotrexate is the commonest. They've got good case series which show its effectiveness. Somewhere between 10 and 20 seems to be the best dose for it. It works reasonably quickly. It works within about 3 to 4 months. So you can use it as a trial before you go on to anything more potent. You can give it subcutaneously as well, and that makes it even more effective. This is a good series which came in clinical and experimental a few years ago. Within 3 months, and this patient used just 10 milligrams of methotrexate, and it was oral. So you can see that there is quite a quick response to nodular prurigo or chronic prurigo. Cyclosporin, you're probably better off reserving it for those who have really severe disease. I mean, the way I use it is to try and switch things off. So if you use it, for about 3 months, just switch things off and then move over to either the methotrexate or the other agents. That would be the best way of using it. And the reason is the more longer you use it at higher doses, the more problems you get with it. So 2 to 5 milligrams per kg body weight, but you know what it can do renally. So long term, particularly because many of these patients will be on the older side, you don't want to risk problems with its long-term use. Neuromodulator is important too. So if you don't have enough success with just immunosuppressing them, some of these neuromodulators may work. So let's look at each one of these: Gabapentinoids, antidepressants, Thalidomide, and opioid receptor antagonists. So amongst the Gabapentinoids, the ones we use most common are gabapentin and pregabalin. So for gabapentin, for older patients, try and use at 100 milligrams at night first, and then slowly titrate up. Don't go on to the 300 milligrams. That's for younger patients. The important thing is to keep titrating up till you reach a phase where they have a little bit of sedation, but they are not having side effects from it. That can be up to 3,600 in younger people, but in older patients, I think we would be struggling to go beyond 600 to 900 milligrams. Pregabalin is more or less the same. Start at about 75, you can go up to 300, but sometimes they say even up to 600. The main limiting factor for both these is sedation. Both of them can cause sedation, and sometimes if they are sleepy the next morning, it's not worth carrying on. Antidepressants can also be used. We've already discussed about what the underlying problems are, and we've discussed that depression is a problem, but also it modulates the nerves. So you can start with paroxetine at about 10 milligrams and then keep working your way up. You can start with duloxetine, usually start at 20 and then keep working up. Amitriptyline, there are various ways of using it. Some authors say start low and keep going up. There's another series in which they gave chronic prurigo patients 60 milligrams for 3 weeks, then 30 milligrams for 3 weeks, then 20 milligrams for 3 weeks, and then they stopped. I don't know how effective that would be, but that was published as a case series too. So there are various ways of using antidepressants. So this can be used in combination with the immunosuppressants and topical steroids that we've already spoken about. I was a bit skeptical about how these neuromodulators alone will work, but this is a patient who had only paroxetine, nothing else. And you can see that there is response. So maybe there is a neuropathic element to it which we need to address if immunological agents alone aren't working. Thalidomide is something very helpful too. Start off at 50. You don't need to go to the really high doses for other inflammatory disorders. The main problem again is its neurotoxicity and its teratogenicity. So most authors have used a dose of between 50 and 100, not very high doses for chronic prurigo. This is a good series actually in the Journal of Dermatology. This 48-year-old gentleman had extensive prurigo. You can see how bad it was on the face. He had only 100 milligrams of thalidomide, and within 4 weeks, he had this dramatic response. It's actually a very interesting series from Asia. There's another 40-year-old gentleman, again, within 8 weeks of using 100 milligrams, and then they brought it down to 50 milligrams as maintenance. So a very low dose of thalidomide seems to work very effectively. The opioid receptors, there seems to be some imbalance between the mu and the kappa opioid receptors. So all these medications try to regularize this discrepancy in opioid antagonists. So naloxone and naltrexone can be used. There's a series in which nearly 2/3 of patients responded. Then you can use nalbuphine and intranasal butorphanol. And I looked it up on the BNF. All of these are available. But the problem is I think they're mostly used by anesthetists. To use it in daily practice in dermatology, I think would be difficult, and they are very expensive as well. You're better off using some of the other agents that we are more familiar with. We come to the final emerging therapies. So these are probably what's going to happen in the next 10 to 20 years. Nemolizumab, dupilumab, neurokinin inhibitor receptors, antagonists, cannabinoids, and of course, you have the JAK inhibitors. Everything is being treated with JAK inhibitors now. So nemolizumab is probably going to be the first biologic specific for nodular prurigo or chronic prurigo. So this came in the New England Journal of Medicine just last year. They had 70 patients, but excellent responses. You can see that there was a 53% reduction compared to just 20%. It was given at a dose of 0.5 milligrams per kg subcutaneously, 0, 4, and 8 weeks. Nemolizumab is IL-31 blocker, which I told you was the main inhibitor of itch. So you can see that we are learning something in the laboratory and then applying it in clinical practice now, which is very, very exciting. So nemolizumab probably is going to be the drug of choice for this specific entity. You can use dupilumab as well. It's an interleukin-4 receptor blocker, but this also plays a small part. And we've already discussed how ATP can be an underlying factor of chronic prurigo. It also inhibits some specific itch pathways. From what I can see, my colleague, Dr. Lister, had a couple of patients with atopic eczema, which is very bad, with chronic prurigo. So he started a couple of patients on dupilumab with, I think, reasonable success. This was a case report. Again, this patient had everything you can think of. You put all those systemic agents, all the neurological blockers, nothing worked. Nearly 10 or 15 different systemic agents had been used. And then with dupilumab, excellent response to the nodular chronic prurigo. The neurokinin 1 receptor antagonists can also be used. This is again part of the itch pathway. There are two of them, aprepitant and serlopitant. Both of them are available even in the BNF. I think again it's used by anesthetists more. There is a topical variant as well. So in the future, maybe we will have access to the topical agent, and that may be something worthwhile considering. But there are reports of systemic agents being helpful as well. Cannabinoids, these are the new ones. So there are two cannabinoid receptors in the skin, 1 and 2, and they are both supposed to be effective in decreasing itching. And again, with the cannabinoids, the tetrahydrocannabinoid, that's the one which gives you the sedative and the one which you can become more sensitized to. But there are other receptors too, which can be blocked by cannabis. So these are all, again, experimental. It can help in chronic itch of any underlying problem. So perhaps in the future, I know that it's not available to us yet, but in the future, these may be agents that we will use in our clinical practice. And finally, the JAK kinase inhibitors. They seem to be very effective in so many inflammatory conditions. We have 3 or 4 JAK inhibitors now for eczema, atopic eczema, and tofacitinib now also seems to be effective for chronic prurigo. Again, it works by reducing the interleukin-31, and it also has an effect on the nerve fiber density. So 2 different ways by which we can learn from the pathogenesis of this condition. And this was a case report which came last year. Tofacitinib with 5 milligrams a day. Again, excellent response. This was within 3 months of treatment. So if you look at how we can approach a patient with chronic prurigo, we're probably going to start with topical agents first. So phototherapy is something which we can use in our practice if topical steroids are not working. The second step, amongst the TCI inhibitors, calcineurin inhibitors, topical pimecrolimus seems to have more evidence than tacrolimus. And then you keep going up the pathway. I think most likely we will go straight to the immunosuppressants. What we have access to at present is methotrexate and cyclosporin, and use that with a low dose of steroids may be helpful. But in the future, perhaps all the newer agents I've talked about, they will be the main ways by which we treat our patients. So take-home points really, we have to understand what chronic prurigo is. It seems to be a new definition which we need to understand. It's an umbrella term. There are so many types of morphologies. But we have to understand the underlying neurological and immunological factors, because if we know that well, then we can treat it well as well. But whatever we do, we know that treatment is incredibly difficult. Thank you, and I'm open to any questions.
Thank you, Paul. That was really informative talk. I'm sure we all have benefited with it. So, any questions? Yeah, would you like to come from?
How about investigations? What investigations do you do when you see these patients?
I think it depends more on, very good question. I think it's the histopathology which is most important for us, because we need clinico-pathological correlation. With regards to hematological investigations, it depends on what drug I think we are going to use. There are no specific sort of investigations for chronic prurigo. If you're thinking of systemic conditions, you look at all the underlying renal and metabolic changes. If you're looking at the medications, you look specific for what you're going to do before you start methotrexate and cyclosporin. There are no diagnostic tests which you have to do for chronic prurigo. It's a clinico-pathological correlation, and you have to look at all the underlying factors, and thereafter the treatment which you're going to use to give this patient.
Thank you. Very useful talk as usual. I have no experience using gabapentin or pregabalin for dermatology. Is it something you routinely prescribe in your clinic, and are GPs happy with us asking GPs to prescribe, or do you have to do it in a dermatology clinic? And what are your experience using it for itch? Because obviously itch is difficult and we want to help our patients.
I have used it quite a lot actually, gabapentin. In fact, one of my first papers was the use of gabapentin for itch of unknown etiology, which we published in 2003. So gabapentin is something I've been using for quite a long period of time, but I used to think that it was only neuropathic conditions which I would use it for. For example, brachioradial pruritus, sometimes for sedation purposes when patients are itching for no obvious reasons. But for nodular prurigo, I haven't used it as much. GPs are usually okay. Once you start it off, and then you tell them, I've started this off, please could you titrate the dose and give rough guidance on what you want, they're usually okay to keep giving repeat prescriptions.
That's very useful. Would you use it first or antidepressants first in this group of patients?
I'd probably use gabapentin first because it has that mild sedative properties. So if I think it's severe enough and they haven't responded to the simpler treatments like topical steroids, phototherapy, I will go on to either methotrexate. I usually use a low dose of prednisolone as well. I know it's not mentioned in many of the books, but I do find prednisolone at low doses very helpful. So I give them a short course of prednisolone, try and switch it off, and then use maybe somewhere between 5 to 10 milligrams of prednisolone with things like gabapentin, and then add in methotrexate as well. So what I do in clinical practice is slightly different from what I've told you now.
Do you think this links into the European guideline for treatment of chronic pruritus without dermatosis that was released in 2018? It gives a really good flowchart of what investigations to do, what to consider in multifactorial things. It's one of the things I see a lot as GPSI. I see a lot of people referred from other GPs with chronic itching, not necessarily yet with prurigo, but with chronic itch without dermatoses. And we do all of those kind of baseline investigations with that mindset, so it's quite nice. And I can back up in terms of neuropathic and brachioradial pruritus if we think that it follows a neuropathic type pattern. A lot of GPs may have already started things like gabapentin, amitriptyline, pregabalin, those type of things to address a neuropathic approach if we think that's there. And I'm just following on from your question about whether you'd start gabapentin or an antidepressant first. With your Dante's Inferno type scenario, patients can come really, really flat and low. So sometimes, because of the chronic condition, they'll be depressed as well. So you can look at a double effect. So there are times when I might go, well, you're really flat and low, we can try adding an antidepressant to see whether or not it picks you up generally as well as helping with your itch.
You're absolutely right. Yeah. So chronic pruritus, I think it's almost like a continuum this into not a chronic prurigo. The only thing which is different is the morphology. With chronic pruritus, you see nothing. Here you see those pruriginous lesions. And again, I agree with you. It's if they have the underlying depression, then you're more likely to benefit from an antidepressant. And you made a very valid point. When it's neuropathic, sometimes they don't come with itching, they come with a burning or a stinging sensation. So straight away you know that it's the nerves and not the skin. So you're better off using the neuropathic type of treatment than the immunological treatment. So excellent point. Yeah. Yes.
When you've got sort of people in their 70s, early 80s who are reluctant to go for systemic therapy, what is your go-to drug for this? Is it injecting triamcinolone or?
I usually use low dose of steroids. Prednisolone is the easiest way. So, I mean, I know many of my colleagues would not like this, but I do use it quite a lot. So, from my point of view, if my 80-year-old patient isn't sleeping, if I can give them 10 milligrams of steroids and give them a good night's sleep, I can keep them on it for months. I don't mind. So as long as the GP is on board with me and doesn't mind me giving, between 5 and 10 milligrams of pred, I think that's a perfectly reasonable treatment. And phototherapy and other harmful drugs. Instead of giving him methotrexate, I'd rather give a low dose of pred with phototherapy.
Got chat exactly like that.
Yeah. Would you like to come to the microphone, please?
The reason for the microphones is actually because recording it for people that are going to listen later and they might not be able to hear, so sorry about that.
So, thank you for the talk. Just a question about phototherapy. So how long do you go on with phototherapy, and do you then do the maintenance dose as well?
There's no maintenance dose per se. The usual period is about 6 to 8 weeks. But for itching per se, you have a bit more flexibility. I'm sure Glenda will tell you that sometimes when you have itching, you can extend it much longer than the 6 to 8 weeks. If they're having a really good response and they say, oh, can I just have another 3 to 4 more weeks? I don't mind using it. Particularly with the older patients, I am a lot more generous because I know I have no other drug to go to. So I don't mind them going on it for 2 to 3 months. Generally, we don't use maintenance treatment in the UK. We give them a short course up to 3 to 4 months and then try and have a break. But as I said, with older patients, my treatment with phototherapy is slightly different. I don't mind giving them more than 1 course a year. I don't mind giving them that much more than a systemic agent. I think it's safer.
Any other questions? Well, I have one, and we have time still. So, have you used, N-acetylcysteine for any cases of prurigo, particularly if they are caused by dermatitis, artifactor type scenario?
I've not used it specific for chronic prurigo. I think with chronic prurigo, they feel that it has to be differentiated from the self-inflicted category. So I've used N-acetylcysteine for trichotillomania and conditions like that, or picking disorders. The problem with chronic prurigo is there seems to be some immunological and neurological problem. Whilst N-acetylcysteine works mainly on that tick behavior where you pick or you pull. So I think the brain pathway is slightly different for that. So if you're looking at the picking sort of pathway, then you're more likely to get success with N-acetylcysteine. So the people who pick their acne and then say they don't pick their acne. So if you have insight and you know you're doing it, it's chronic prurigo. If you're doing it and you then tell, oh, I'm not doing it, then you're more likely to go into N-acetylcysteine. So it's a slightly different chemical, and I think it has to be in a slightly different way.
Sure, yeah, thanks. And also, the other thing is, often patients with prurigo, chronic prurigo, are on polypharmacy, lots of medications. So do you think that the medications or drugs have any etiological factor?
Yeah, definitely, yes. I'm sure drugs do play a major part in all of this. The problem is we don't know which drug it is, and sometimes trying to stop one drug alone wouldn't work because there are so many other medical problems. So to try and extricate the medical problem from the drug problem, it's almost impossible. What I usually tell my patients is try and get the statins down as low as possible, try and keep away from calcium channel blockers if you can, particularly if there are 4 or 5 antihypertensives, try and remove 1 or 2. I try and reduce the drugs, but in the end, with drugs you don't win, that's the problem.
Unless there's a specific history with the drug, because I've had a few cases where if you ask, they go, well, it started after I started Adazem or something, and you go, oh, can you just try stopping it, please? And they stop it and go, oh, I've had one recently came back, oh, it's all gone, I have no symptoms at all. She's had 2 years worth of itching, being on Adazem, and then managed to stop it, changed it to something else, and it went away. I had zero faith this was going to work, and then she came back and shocked me. So.
I think calcium channel blockers do seem to, for some reason, the skin doesn't like it. I think. At least it's not my favorite from a hypertension point of view.
Brilliant. Thank you very much.
Thank you.
Thanks.